Before I get started, I'd like to know in the audience how many people are pretty familiar with value-based payment? Okay, just a few, but that's good because I'm going to try to tell you as much as I can in a short amount of time here today. One of the things, though, that I think you'll see is that McFarland Clinic and Mary Greeley are both high in quality and high in value. So there we are. So value is defined as quality, service, and safety divided by cost. So what that means is by increasing quality or by reducing cost increases, that will increase value. So that's what we are looking for. Now, I'm going to spend a little time on the healthcare costs, and I'm sorry that these figures are kind of going to make you dizzy, but I want to just show you what value is all about because the costs are a big part of the value equation. Right now, $4.8 trillion is spent on healthcare, and that is about $14,400 per person in the United States. We're way ahead of other countries. In fact, Switzerland is the next highest country, and yet our quality is not the highest. In fact, our quality defined by mortality, access, equitable quality, and administrative costs is actually among the lowest in developed countries. And so right now, about 18% of all of our dollars are spent on healthcare, and that's almost 1/5 of our overall costs in this country. So that means if someone has a salary of $10,000, they're spending about 1/5 of that on their healthcare. Now, my quiz here is, what is the entity that pays the largest part of healthcare in this country? Is it Medicare? Is it Medicaid? Is it the employees with their premiums and their out-of-pocket payments? Or is it the private employers? Or is it someone else? So how many think it's the Medicare that pays the most? No, I think you probably, okay, I guess we did get somebody who thought. Actually, do you think it's the employees who, with their premiums and their out-of-pocket costs, are paying the most? No, it's the employers. And I'll talk about what our local employers are spending on healthcare in a little bit, but private employers are spending 29% of all the healthcare dollars, and Medicare is about 21% of the payments, and Medicaid is about 18%, and employees are not paying a whole lot. So here's another quiz. What is the cost of a family coverage in the United States? Not Iowa, but in the United States. What is the amount of the premium for those families of 4 that are getting their health care coverage through their employer? So how many think it's $6,000 a year? Okay, how about 10,000? Okay, raise your hand if you think it's $16,000. Okay, it's actually $24,000. Now, luckily, in Iowa, we don't spend as much. There are geographic variations, and in California, New York City, for example, those costs of healthcare are much higher than they are in Iowa. And there is a variability in Iowa, too, depending upon where you get your care. But overall, Iowa is in the lowest 3 states in the cost of healthcare. And it's often 30% lower than the average that is spent on healthcare. It's about half the cost of care in California and in New York City. So as I said, the cost of a family coverage is $24,000 a year, and the average employer in this country pays $17,500 for one employee and their family. The employee is actually paying about 27% of that $24,000 per year. And a single coverage is not as expensive. The employer pays about 83% of that, which is $8,400. And the employee is only paying about 17%. I don't know exactly what Mary Greeley pays, but at McFarland Clinic, we try to shoot for 85% is paid by the employer and 15% is paid by the employee. And in the country, the average employee gets benefits from the employer that are about $13 an hour for their health care and retirement benefits, and then their wages are about $30. So you can see that's a pretty big share of their take-home pay per year. And then 61% of Americans have employee or sponsored health insurance. And that's 165 million Americans. And then Medicare covers about 66 million Americans. And then Medicaid covers 74 million Americans. And there are still 25 million uninsured in this country. So what's happened over the years with the high cost of health care is that more employers are self-insuring, and about 74% of large employers are self-insured. That means they actually pay the costs of the care, and it might be pretty high one year. What happens with a smaller employee is that if an employee gets really sick, then the insurance company would increase the premiums because it costs so much. And so the smaller employers are getting out of they're trying to pay their own premiums, and even some of the smaller employers are now self-insuring. They do use an insurance product for the catastrophic cases. And so there's been some concern that with these 4 to 5% increases year after year, will employers demand that the government pay for their health care? In other words, it may be the employers that will be saying that they want the government to pay for health care or Medicare for all. Sorry. Okay, so what are the average costs now if you went to see your doctor in the office? What would an emergency department visit cost? And what would a routine hospital stay, let's say a case of COVID or a simple pneumonia? What would those costs be? And then, for example, a little more sickness with, for example, sepsis, and the patient stays in the ICU and has a 5 to 6 period of time in a rehabilitation center recovering from that. So those are staggering costs, okay? An office visit is between $100 and $150. Remember, Iowa is on the lower end of these costs, but again, this is what the nation is looking at. An emergency department visit is about $1,500 on average in higher cost states. And then if you have a patient with sepsis, their cost could be as high as $500,000. Lumbar fusions are between $50,000 and $150,000, again, varying from hospital to hospital and state to state. The averages, like I say, are higher even than that in some states. So my question now is, what is the average per person increase in the cost since 1965? So is it 3 times as expensive per person? Is it 7 times higher per person? Is it 23 times higher, or is it 68 times higher? So I won't ask you to raise your hands, but right now it's 68 times higher than it was in 1965. So if you're looking at per person costs, it went from $210 per person back in 1965, and now it is $14,400 per person. So do the math, and that's 68 times as expensive. Now you may say, oh, but inflation, what's a dollar worth now? Well, a dollar back in 1965 would be equal to $10 now. So if you do the math, that still works out to the healthcare costs are 6.86 times higher than they were per person back in 1965. So now I'm going to talk about quality because I wanted to get that denominator set, that is the high cost of healthcare, because higher costs drive down the value. And so we want to increase value by increasing quality and hopefully limiting those costs. So how can we improve quality? And how did the cost and quality awareness bring about change in healthcare? Between 1965 and 1970, the costs of healthcare actually doubled. By 1970, the healthcare costs had doubled from 1965 to 1970. Does anybody want to give me a guess as to why that happened? Do you remember when Medicare was passed? Medicare was passed in 1964, so 1965 was the first year that the costs started to go up, and then by 1970, 3/4 of Americans in 1970 said that we had a healthcare crisis. 1970, 3/4 of Americans said we have a healthcare crisis. And that was when the government started to push HMOs, and I think everybody knows about HMOs. It actually peaked in the 1980s and 1990s, and there are still HMOs. Wellmark still offers an HMO product now that's a little bit cheaper than their preferred provider organization premiums. McFarland Clinic and Mary Greeley are a preferred provider for some businesses. That is, if our McFarland Clinic employees go to a McFarland Clinic provider, they pay less, or if a business goes to McFarland Clinic provider, they pay less co-pays or out-of-pocket costs. So that's what a preferred provider is, and McFarland Clinic and Mary Greeley both do that. Now, in the 1970s, those costs started to increase because Medicare was paying the bill. And finally, in 1983, the hospitals were told that they had a limit to their costs because the hospitals would simply charge more for a patient being in the hospital 10 days than they would charge for a patient staying in the hospital for 7 days. And so there was this incentive for hospitals to keep people in the hospital longer. So this is why DRGs, or diagnosis-related groups, began. So if you had a stroke, for example, you would have a certain amount of time in the hospital, and that would be the DRG cost or payment to the hospital. And if you had the patient stay in the hospital longer, they would not pay anymore. Medicare would not pay anymore. So those DRGs began in 1983, and then a physician usual and customary fees were changed to what we call relative value units. And every physician knows what relative value units are because that's still the way that we are paid for fee for service. When we do a service, we get paid. And those RVUs would measure the amount of time, the effort, and the practice costs, as well as malpractice costs. And that's how an RVU would be paid. Now, back in 1998, the conversion factor was $38, and $38 was the fee for one RVU. So that conversion factor in 1998 was $38 per RVU. And guess what that RVU is now by Medicare? It's $32. So in 26 years, this conversion factor has gone down by about 16%, despite the inflation. So physicians are getting paid much less for each unit of work. I've been a critic of the geographic adjustments by Medicare, and I could spend at least an hour on that, so I'm going to skip that over. But that's my pet project, is trying to avoid that. But the critical access hospitals were actually conceived in 1997, so that meant that every rural hospital that had a small census would actually get a cost plus reimbursement. They would get their costs. They just had to show their costs, which were so much, and they would get 1% more. So rural hospitals have been getting that cost plus arrangement through the Critical Access Hospital Program. There was no cost plus program for physicians. Physicians have been reducing the amount that Medicare pays them by quite a lot. There was a sustainable growth rate called the SGR that began in 1997, and physicians for a number of years until Congress eliminated the SGR, there were 5% penalties or 5% cuts in physician payment. That's why I told you the conversion factor went down over the years. Okay, so finally people got upset with these high costs, and there were, like I say, there were things that Medicare did to try to reduce costs or at least limit the costs. And so who recalls what the Clinton healthcare plan was? I don't think all of you in here were even born at that time, but it's the reason that Hillary Clinton was so disliked, because of the Clinton healthcare plan. What the Clinton healthcare plan was in 1993, it was actually supported by 71% of the public when they first came out with the Clinton healthcare plan. But when people learned more about it, then they got the Congress to fail to pass that. And so the support went from 71% to 43%. But what the Clinton healthcare plan did feature was on their benefits. They had what's called managed competition. The Clinton healthcare plan wanted physicians to join an organization and have managed competition, like an HMO that would reduce the costs. There was a price control. There was a ban on higher premiums for pre-existing conditions, which I think you do recall that was finally passed by Obamacare. That's the higher premium for the ban on higher premiums for pre-existing conditions. So again, the healthcare insurers didn't like it. Healthcare organizations like the AMA didn't like it. The Republicans obviously didn't like it because it was big government. Now, that didn't solve much. In fact, the number of uninsured patients back in 1993 was 14% of Americans were uninsured. And then by the time Obamacare was finally passed, it was even higher than that. It was 1 in 6 Americans, or 16% of Americans, were uninsured. And then Obamacare, with expanding Medicaid and with the private subsidies for buying insurance, Obamacare reduced the total number of uninsured to about 9% of the public. But the research by Dartmouth in 1996 through 2010 showed a marked variation in regional healthcare quality, costs, utilization, and outcomes. And Iowa was one of the best states for value, according to the Dartmouth Research Project. And then the research by Dartmouth showed that overutilization, that is, using more tests, treatment, and so on, that is more volume of care, actually just simply increased the cost and didn't really increase the quality of the care. They thought that perhaps 20% of all the healthcare costs were due to inappropriate care. So as I was saying, more volume of fee-for-service payments to hospitals and physicians meant that there was actually less value. And like I say, Iowa was an exception with high quality, low cost of care. And what Dartmouth did and some other quality organizations did, they actually showed that higher quality, like in Iowa, and lower costs actually were related. So a higher quality meant lower costs. You may think, oh, well, higher quality must cost more. No, it's not. It's the opposite. Okay, so one of the things I want to talk about is quality now. And to prove that you are actually improving quality, you have to measure it. Otherwise, you're just simply saying, well, our quality was much greater this year than last year. Well, how can you prove that? It's what I'll talk about now are the various types of quality measures, and some of the quality measures that you probably heard about really didn't matter. So I'm going to talk more about the measures that matter. In 2001, there was a big push, and it was by the Institute of Medicine and the Institute of Healthcare Improvement. And it was called Crossing the Quality Chasm. And it showed that there was a large quality gap in this country. And it showed some of the causes, and it promoted a system approach to improve healthcare quality and outcomes. And then in 2003, Medicare began to pay for performance, that is, pay for improvement in quality measures. And then there was another campaign called 100,000 Lives by the Institute for Healthcare Improvement that actually did have significant improvements in quality, and more quality organizations were formed. So healthcare quality is defined as the degree to which services increase the desired health outcomes for individuals and populations. And the 6 aims of quality were that it was safe, effective, efficient, patient-centered, not provider-centered, patient-centered, timely, that meant good access, and equitable, that is, you didn't discriminate against some groups. So as I said, you have to measure quality to prove that you're doing better. And quality measurement developed rapidly in the 2000s, and since then, I would say that we probably jettisoned many of those quality measures that were just checking the boxes or doing some irrelevant improvements. Now, if you don't know the difference between outcome and process measures, outcome measures an outcome. That is, if the patient was able to stay out of the hospital despite the fact they had a disease, that's a good outcome. The patient appreciates not going into the hospital. The patient appreciates not going to the emergency department. The patient would rather be healthy and at home. And so an outcome measure can be all of those. It can be measuring how many hospital admissions there were, it can measure how many emergency department visits there were. One of the best quality measures that McFarland Clinic had in 2010 was actually a measure of diabetic patients. How many patients with diabetes were admitted to the hospital in 1 year? Okay, well, if the patient didn't have a diabetic complication, like kidney failure, a heart attack, a stroke, didn't have an amputation, and didn't have another complication of their diabetes, that's good, okay? And McFarland Clinic actually showed with their quality measures that for a patient who had diabetes, their chances of being in the hospital in 1 year's time were 1/2 the national average. So we take much better care of diabetic patients, and that's an outcome measure, and the patients appreciate it, and so do the payers appreciate that. So that's a good example of a quality measure, and that was something we had in 2010 because they finally got around to measuring these things. They also measured congestive heart failure and COPD. And we were about 3/4 as often admitting a patient with those two diseases as the national average. So again, if you think, well, how do we know we're higher quality? Well, these are quality measures that we can show. So a process measure is not as good. For example, if you were measuring some quality measure in the emergency department, and you wanted to know, did you give an antibiotic for that pneumonia? Oh, yeah, we did. Oh, except the patient had congestive heart failure. They didn't have pneumonia. And then, oh, we gave aspirin to that person who came in with some pain, except they didn't have a heart attack. They actually had a bleeding ulcer. So you gave aspirin for a bleeding ulcer. That's not too good. So process measures are helpful, but they're not as good because, unfortunately, there's still a number of diagnosis errors in the United States. Now, there is also a structural measure of quality, and that's for capacity or access. Did you get that patient in quickly for their particular problem? So as I said, there are numerous measures that were developed, and many of them had difficulty tracking because did you check the box or how did you measure that you did the right thing? And so data from claims was easy. You were either admitted to the hospital or you weren't admitted to the hospital. So that was claims data. That was easy to obtain. And that's the same for procedures or costs. There were procedures, for example, cardiac catheterizations in one community in Ohio, that the rate of admission to the hospital for cardiac catheterization was 4 times higher for that population than it was at the Cleveland Clinic in Ohio. So that was an example of were the 4 times as many cardiac catheterizations needed in this community. So that was an example of an outcome measure because you either did that cardiac cath or you didn't. So misdiagnosis, like I say, can sometimes complicate any measurements and claims because some people are getting unnecessary treatment for misdiagnoses. Okay, so value-based payment reform. Accountable care organizations are something that I'll talk about a little bit more. And that's the most common type of value-based payment reform. But pay-for-performance actually started before ACOs. And then bundles or episodes of care. For example, a patient who was admitted to the hospital for hip replacement, an orthopedic surgeon and their group would get a certain dollar amount. And so you did your best to try to make sure that if they didn't need to see the orthopedic surgeon, but the nurse practitioner followed them up or a nurse gave them the information that they needed, as long as they give good care, that bundle was a dollar that was fixed. And so the orthopedic surgeons decided, oh yeah, maybe I should hire some nurse practitioners and then I can save my time for the really important and critical things that they do. And then, of course, capitation, which is kind of the strategy with health maintenance organizations. You get a certain amount of dollars to take care of this many patients per year. So these are all the quality and value initiatives at McFarland Clinic. And like I say, in 2010, the Quality Resource Utilization Report, we did very well with diabetes, COPD, and congestive heart failure. And then in 2012, ACOs were started. They had 22 measures. And then we at McFarland Clinic joined the Wellmark ACO in 2013. And the Medicare ACO in 2014. And we have done extremely well every year for both the Medicare ACO and the Wellmark ACO. Wellmark started with 16 measures, and now they're down to 9. I won't go over all of them, but these are basically measures that the primary care physicians are mostly trying to keep their panel of patients doing. And these are preventive type things. If you catch a cancer early, it's going to be a lot easier and cheaper to treat. So that was the purpose for some of these measures. You've got to do the screening test to pick these cancers up quickly. And then they have 4 age groups, including kids, that have to have prevention visits. And then the ED visits and radiology services per 100,000 patients. McFarland Clinic excels in all of these except for the radiology services per 100,000, but that's a little debatable because we have so many oncologists and other specialists that do more radiology services. And this is what Mary Greeley has as their panel for value-based quality measures. There are outcome measures such as complications of hip and knee surgery. There are measures that are patient surveys, their engagement, their communication, the care transitions. When they went home, did they get the right instructions? An overall rating of the hospital. So some of these are outcome measures, some of these are surveys, and of course a survey is an outcome measure. I mean, did you have a good experience at Mary Greeley? Yes. And then infections. The Quality Council here at Mary Greeley keeps track of all these complications, like a surgical site infection, a urinary tract infection, MRSA infections. And then the sepsis. There's a sepsis bundle that is the only process measure out of this whole group of value-based quality measures for Mary Greeley. And then these are some of the key indicators, not necessarily the quality measures as much as they are. Did you do the right thing? Did you keep somebody from going into the hospital? Because they're keeping track of the discharges. They're keeping track of the emergency visits. If you kept that patient from having a complication of their illness and they did not have to go to the hospital, that's good, okay? That's good for the patient, that's good for the provider. And then the skilled nursing facility days, if you have a better outcome after your surgery or better outcome after your sepsis and you didn't need to go to skilled care, that's a good thing. Or the shorter they spend in the skilled nursing facility, that's a good thing. And then 30-day readmissions. If you solve the patient's problem, like their congestive heart failure, and you kept them in good shape after their hospital stay and they didn't need to be readmitted, well, that's a good thing. That's an indicator. Then annual wellness visits. I know some people say, well, I went to my physician for my yearly physical and the doctor didn't even touch me. And I say, well, an annual wellness visit is an annual wellness visit, and it's not necessarily a physical exam. In fact, there have been some concerns that other than blood pressures, doing a physical exam can find all kinds of irrelevant things that are chased by the physician. So there's still some debate about what a yearly physical is, but an annual wellness visit is not necessarily a physical. And one of the other measures that this is for high-risk patients that have a chronic disease like diabetes, like cancer, did you have annual wellness visits with those patients who are at high risk of bouncing back into the hospital? And as I told you, an emergency department visit is 10 times greater than an office visit. And a hospital visit is 100 times more expensive than an office visit. So if you were running a value-based care organization, you would want to have more office visits. You would want to have more ED visits than hospitalizations. So that's why these things are all important. And then at the clinic, we have a chronic care management team called Population Health, and they do a lot of things with patients to try to keep them healthy and out of the hospital. The diabetic educators at Mary Greeley are a good example of if they manage their diabetes much better, they will have fewer complications. The HCC is a coding initiative because ACOs get paid by the sickness level of the patients. In other words, if your patient is sicker, that is, has diabetes or has cancer or COPD, those are going to be more expensive. And so the risk score of that patient, or the HCC code, hierarchical coding category, that is what we measure and show that our patients are sicker, and so we need to have a little higher budget for our ACO. Now, the per patient per year spending is something I want to talk about here and have everybody really get this. The average patient in Medicare, not the drug costs, but the average patient in Medicare is spending $15,500 per year. Guess what McFarland Clinic's average Medicare patients are costing the government? $11,000, almost 2/3. So I don't want to say it's all because of our physicians or our hospital. We do want to make sure our patients are engaged, like our diabetic patients are engaged with us. We want to make sure the COPD and the congestive heart failure patients are engaged with us. So that's how we can reduce their hospital stays, reduce the costs, and improve their outcomes. Now, low-value tests and treatments have been advertised, and there was an initiative over the past 10 years or so called Choosing Wisely, and we use Choosing Wisely as an example for some of our specialty departments, for them to take the initiative to do something different that would actually improve the quality of care and reduce the cost. So we focused with the Choosing Wisely on low-value services that really don't make a whole lot of difference. So they increase the risk of harm because they may find something that was just incidental, and then you're chasing that with more tests and more treatment. And that's where some states like in Florida and Texas, they would chase all these incidental findings and then spend all kinds of things and then increase the patient's anxiety over what was found. And I have already talked about the yearly physical controversy, but we want annual wellness visits, not necessarily a yearly physical. But blood pressure is important. The measures that are important for Medicare are every time a patient goes to McFarland Clinic, they are going to get a blood pressure check, and they're going to have a fall screen risk assessment. That is, have you fallen once in the past year? Are you afraid of falling? There's a depression screen. Those are quality measures for Medicare. We also have a vaccine percentage of our patients that are getting vaccines, and the hemoglobin A1C for diabetic patients is actually, we have 90% of our patients with diabetes whose hemoglobin A1C is less than 8. And that's near the top in the country. So these quality measures are really quite important. So I'm going to have to give another talk another day on accountable care organizations, because I could just like with the geographic practice cost indexes, it's way more complicated than I can try to cover here, but I'm just going to mention a few things. You were wondering how many people are in an ACO. Well, 94 million Americans are currently in an ACO, and probably everybody in this room is in the McFarland Clinic ACO, and Mary Greeley is a partner with our ACO. So 94 million Americans, about 50 to 55% of primary care physicians are in an ACO. And that means everybody at McFarland Clinic is in the ACO. But 40% of the nation's specialists are actually under an ACO. And I recently gave a talk, and most of the physicians in the room had no idea that their academic institution was actually part of an ACO. So a lot of physicians don't even know that they're part of an ACO. But patients are attributed to the ACO by their primary care provider. And if you forgot that you received a letter once a year saying you're in an ACO, and if you have any questions about it, please call this number. So if you don't realize you're part of an ACO, you are. ACOs are paid by shared savings. That is, there's a budgeted amount depending upon last year's spending, and then a budget of what you might spend on the same panel of patients next year. And McFarland Clinic has over 30,000 in the Wellmark ACO and about 15,000 some in the Medicare ACO. So the budget for that is about $11,000 per patient for the Medicare patients, and the Wellmark patients are quite a bit less than that. So if you don't spend all that budgeted amount, then the shared savings that are accrued, you get a percentage of that back. It's usually about 50%, although right now we have a Wellmark ACO that's paying us back 70% if we do have some shared savings, and we have every year. Okay, and then integrated and managed care is a hallmark of the accountable care organizations. It's having a pharmacist that can help to decide the right medications for a patient with an infection. So that's an integration of care, not just integrated with physicians that are primary care and specialists, but also, for example, pharmacists or diabetic educators are part of that same system of care. You need patient data that is timely because you can't manage an illness if you don't know what's going on. I said risk coding so that you get paid more if your patients are sicker. And then there's upside risk, which is if you have a surplus, that is if you didn't hit the budget and you saved a lot of money, that's called upside risk. Most ACOs are upside risk, but 25% of ACOs now have downside risk. So if you spend more than the budget, then that downside risk means the group has to pay back some of those dollars that were over the budget. And then, as I said, population health is a department at the clinic. I think they have about 18 medical assistants. It might be more than 20 now, but they help to manage chronic disease and the frequent flyers from the emergency department and care transitions. And the partnership between Mary Greeley and McFarland Clinic is tremendous, and we're very fortunate to have such a great integrated organization here. So I do have time for questions. So I presented a whole lot of information, and I hope I didn't leave you behind. But if you have a handout, you can read the handout too. So,
do you think new measures in social determinants of health will have an effect on these like risk benchmarks and this population health overall for reimbursement?
Yes, the question, if you didn't hear it, is social determinants or social drivers of health are very important. And so it's very important for an ACO that has to be accountable for those patients who have drivers that make them more ill than another person who doesn't have those social drivers of health. So the social determinants of health are very important. And so I do think it'll probably be part of that risk as well. I don't think we have it yet, but I think it will be. So it's a good question. Okay, well, you can always contact me if you have any other questions, but thanks, sir, for listening.